Institute. We are getting ready to start our last surgery for today. It's a bilateral Deuk laser disc repair, L4-5. Well, actually, it's L4-5 one side, L5-S1 the other. Our patient has a grade 1 listhesis, spondylolisthesis, with a pars defect at L5-S1. They also have vascular grafts, which I did not put in. They were put in before. And he has two discs that are herniated, one bulging disc at L4-5 and one herniated disc at L5-S1. Okay, and L5-S1, we are going on the left side. This is the left side. You can see he's also had an RFA, radio frequency ablation. Just lay still. Shot. All right, so I need to see in the back of the spine more.
Can we lower the table down, doctor?
Sure, table coming down. Coming down. Is that okay for you?
Yeah, it's good, it's good. Shot. All right, it looks pretty good. Can actually start a little higher. So what I have to do is get into the L5-S1 disc space. I'm doing that with a transforaminal approach. Transforaminal means across the foramen. The foramen we're talking about is the neural foramen. Shot. Not an easy thing to do given the fact that this patient has the abnormal alignment of his L5 and S1. You may be wondering, Dr. Deuk, you ever get to a situation where you can't access the disc? The answer is yes. I have. It doesn't happen often, but it has happened. There are some people who I just cannot get into the disc. Shot? All right. So we're awfully close here. Shot? Let's get an AP. I want to look on the AP view, front back view, to make sure that I'm close enough to the corner of the disc. Hey, we are. No? All right. Now, while he's still snoozing a little bit,
A little left over from the RFA.
I'm gonna go on the other side and get close, and then we can get in there at the same time.
He just has a little residual, I think. From the
Hey,
RFA. Sorry about that.
no problem. I'm happy because he hasn't bothered me at all during this first part.
Watch the table.
He's been very peaceful and quiet and comfortably sleeping. So let's see what I can do at 4-5.
So those tables,
Interesting.
you can, lift that a little bit.
So they're not in the way. Go ahead. Lift it.
There you
Shot.
There you go.
All right. So a little too high
That's good.
there.
Let's go up there.
Shot. 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 Don't move. Shot. You're doing great. We're almost there. Shot. Shot. So some people call, when you use spinal needles on the spine, shot, they call the doctor a needle jockey, and that's actually, I think, fairly accurate statement, because we are jockeying that needle to go exactly in the right spot. Shot. All right, AP. So I've got both needles pretty darn close to where I want them. I just want my patient to be a little more awake and responsive. You can see he's got a pretty high iliac crest. Looks good. And you can also see he's got a history of an aneurysm, right? That's why he's got the mesh there. So we call that a stent. The mesh is part of what's called a stent. And again, I'm not a vascular surgeon, but shot. So I didn't have anything to do with the stents. All right, are you awake?
How you doing, buddy?
You awake?
Yes or no? You awake? Yeah.
All right. Are you comfortable?
You having any pain? Are you having pain?
Yeah.
Huh? No? He said no.
All right. So first I'm going to place 4-5. I can feel the herniation here. And then I'm going to do 5-1. You think he's responsive enough to be reliable?
Yeah.
Okay. Can you hear me? Are you feeling any pain?
Are you having any pain? In your back or your
Shot.
back, you said?
Shot. So we're right here at 5-1. Yeah. Not bad. Definitely in. In like the person doing the broadcast, Flynn. Okay, so we access 5-1 on the left. Everybody agree that's correct, Luis? And we access 4-5 on the right. So our patient has a herniated disc at, where's my marker? At L4-5, which is, this is L4-5 disc, and it's really off to the right side. And then he's got a L5-S1 disc problem off to the left. But he also has a slippage. You could see the bone slipping. It's around probably a 25 to probably a 30% slip. So it's probably a grade 1 to grade 2. Are you awake?
You said yeah.
Now, how much of your problem is back pain or versus leg pain? What percent is back pain?
What do you say, Edward? What percent? 50-50? 80-20? 80.
80% what? Back or leg?
Back pain.
Back, all right. Are you comfortable?
You said yeah.
How bad is that on a scale of 1 to 10? Is that where you typically get back pain? All right, we found one of your bad discs. That was the bottom one, L5-S1. So we had 10 out of 10 pain at L5-S1. Are you better? All right, is it gone away?
I just put in this advance, but this is next.
Is it better?
Is your pain better? A little bit better.
All right. So basically, I just tested the bottom disc because I know the bottom disc based on his location where he points to and based on the MRI. I know the bottom disc. I believe it's going to be painful, and that's why we came here to do the surgery today on the bottom disc, the L5-S1. The L5-S1 disc, I believe based on my exam of the patient in clinic, plus based on his MRI, combining the two, that this disc was a source of his back pain. And I just confirmed that. It's 10 out of 10 concordant. Okay? But we haven't tested the other one. Can you guys hear that? How bad is that on a scale of 1 to 10?
Not 10, you said.
10. So we got another 10. Is that where you get back pain typically? You get to go to sleep. So he has concordant pain at L4-5 as well. So basically, using my diagnostic ability in clinic from doing this for many years, and based on using the MRI and the nerve tests and everything else we do at Deuk Spine Institute, we identified the source of his back pain as being 2 discs and the facet joints. The facet joints have been treated with a rhizotomy, and now we're going to fix the 2 discs with the laser surgery. All right. Now we're going to start at 5-1. Shot. So I've got the guide wire in. Shot. And I'm going to now take the needle out. And of course, you know, I have to be careful because this patient has a vascular condition. And this patient would not be a candidate for open surgery because he's, you know, got a lot of vascular issues. But he's a perfect candidate for Deuk laser disc repair. Endoscopic surgery. Local? I want to try to give him as much local as I can. Make him comfortable. Huh?
I'm going after his blood pressure.
Hey, do what's best for the patient. I can live with whatever you got. All right, well, I just, you know, the only thing I'm worried about is a muscle, which is just protracted pain. All right, keeping an eye on my dilator tip as well as my guide wire shot. Getting past this, basically a fracture in the pars, which is the bone that holds the L5 to the S1. Mallet. And so I'm going to advance the dilator now past the facet and into the foramen and into the L5-S1 disc. Shot. So we're right there at the back of that disc. Shot. And because our anesthesiologist has done such a fine job, we're able to get into that disc. Shot. Nicely. Let me have the mallet.
Make sure they got wired. We saw it.
Shot. All right, that looks good. That looks really good. So we are inside the L5-S1 disc that's damaged from the left side, and now I'm bringing my tube down that I'm going to do the entire surgery through this tube. Shot. 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 Okay, take that. Remover. Luis. Taking my, this is my dilator. That's out. We're ready to go. You can see the tube is inside that 5-1 disc space nicely. I think it's here. Yeah, so you're good. All right, let's go ahead and show our audience why do herniated discs cause back pain? Because there's a reason, and we discovered that reason at Deuk Spine Institute. Unfortunately, 98% of the rest of the world doesn't know this yet, and we've been trying to teach everybody why herniated discs cause back pain and that they can be fixed quite easily with endoscopic spine surgery, specifically Deuk laser disc repair.
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
Welcome back. Dr. Deuk Majan here. And the blue thing is the laser fiber. It takes energy from the actual laser itself, which is at the patient's feet. It's a big machine, and it delivers that energy right to the tip, the glass fiber tip, what you're seeing. Believe it or not, this little glass fiber tip is very expensive. It costs about, how many hundreds of these things cost? 250, 300 bucks? Luis?
What do you mean?
The laser fiber.
Oh, this is $950.
Oh, $1,000. Okay, I'm off a little bit. It's $1,000 laser fiber. So, yeah, very expensive. Anyway, the fiber brings the energy from the laser right to the disc. And for everybody that's ever asked me questions, well, can you fix it if it's bone on bone? Look right there, that pink surface to the left, that flat surface there, it's at about 9 o'clock. That is the bone. And then the other bone is to the right there at 3 o'clock. And this is bone on bone. This L5-S1 is bone on bone. So how come I can cure pain from an L5-S1 when it's bone on bone? The answer is, you watch my video that you just played, go back and rewind it and you'll understand why. Because the pain doesn't come from bone on bone. It comes from the annular tear. It's what I've been saying for 16 years and published. But unfortunately, people don't listen. This is where the pain comes from, right here. You can actually see all the inflammatory tissue. Who's pulled this out? Huh? Someone pulled the fiber out. Don't pull the fiber out. So we're going to get rid of his back pain, and we didn't even put a cage or do a fusion. We're going to get rid of the back pain without a cage and without a fusion. Cages and fusions are no longer necessary. They are completely obsolete. Completely obsolete. Okay? If you ask me what's more obsolete, an SLR camera or, and I'm not talking about a digital SLR, I'm talking about the original SLR cameras, the ones that have film. An SLR camera, is that more obsolete or is the fusion more obsolete? The actual fusion is more obsolete. Nobody uses SLR cameras anymore. They use digital SLRs, but not the original Kodak film SLR cameras. Nobody does film processing. Those are gone. How did this come out? How did it come out? All I did was do this, and somehow it came all the way out. Oh, you're not pulling it out, right?
No.
All right.
Yeah, you want to keep it here. Sometimes with the hand you have it, obviously, the cable around, okay?
Just about done here at this disc. This again is the L5-S1, and it's from the left side. By the way, for those of you wondering, everything we use is FDA approved, 100%. So the procedure is done with FDA approved approval.
So I think then the L5 switching from the fiber to this, so
I need, yeah, just relax. You're doing fine. Everything's okay, huh? Well, you know this is, I've always told you, this is going to be the most sensitive area. What are you saying?
he was leaning more towards this, so I said,
Yeah, you want to support him. He's strapped in, but you still want to support him. Okay? Patients sometimes move a little bit.
watch your face, watch his face, okay?
You got it?
Yeah, he's done. What happens, Oscar? Are you done with that level, sir?
I'm not done.
You want the rubber?
Just about done here.
So grab these very good, alright? Yeah. Alright, have control of this. Now he's coming with that to white. So with your other hands, you grab the rubber, alright? With your other hands, grab the rubber. Yeah. Right? And then you wanna, you see? On this side. Because if you go like this, we're gonna close it, right? To this side. Okay.
Hold the tube. Hold the tube. Thanks. All right, we're done with this.
Alright, nice on, please. Scope off, please. Thank you.
Scope off.
That's good.
Irrigation.
Alright, the next thing after that is gonna be irrigation. Right?
Here you go. Take that. Watch the needles. Don't poke yourself.
Like this.
So we're done with the left 5-1.
It's gonna need to all these guys. Usually he do 2 flushes. Okay. Just be careful with the needle. Give it to him. Okay. Now he's gonna need these again, and then they can allow. All right. Sure.
Any questions from our audience so far?
No current questions, Doc.
Yeah.
All right, taking our tube out. Take that.
Cool. There you go. Right here. And then you have to move back closer because the X-ray is coming in.
So we've just finished the left L5-S1. Move over. You never want to touch any of this. Watch the scope. Wait, you cannot touch the back. You cannot touch the back of your arm with that laser. Come forward a little bit. Okay. You got to be aware of where you are.
I can if you want to go first.
Yep. If you contaminate, if you touch something non-sterile, Oscar, you just say, "Up, I contaminated my arm," and we'll get you a new gown or a sterile sleeve. Okay. In the very beginning, when you're learning about sterile fields and sterile technique, even I made mistakes, you know. Everybody does. You bump something you're not supposed to bump, right? Yeah. So I guess there was an OB-GYN that got in trouble. Did you hear about this guy? He was doing insemination of his patients with his own sperm.
Wait, what?
Yeah. You know how some people are infertile and they go to the OB-GYN for fertility problems, like to have, male sperm injected so they can have a baby. Females do. Well, he was using his own sperm. Well, I mean, look, I'm going to go out there and put my neck in the noose, but I kind of have mixed feelings about it. So my dad was one of the first OB-GYNs in the country that did infertility back in the 70s and 80s. Okay? Literally one of the first. And he was a professor at USC, School of Medicine. And they used to hire this guy, my mom told me, to come in and, produce. This one guy, he was popular for some reason. I don't know. I wasn't there. It kind of grosses me out. Point is, he was the guy. And, he made a lot of money, I'm sure, donating. But the point is this is a doctor donating. Is that, I guess it's unethical. Right? But why is it okay to use some random guy when you can't use a doctor? I mean, I guess there's obviously an ethical reason. Maybe he could have just offered. Apparently, like there's 30 kids that he's the, and I'm sure the patients are pretty upset about it, obviously. He's getting sued. I'm just glad I'm not in that business. Okie dokie. We are now at the L4-5 from the right side.
You seem to tolerate that pretty good. You seem to tolerate that pretty
Good. Yeah, well, we're a little bit further. I want to bring it back a little bit. Okie dokie. And he's strapped in good? But that was one of the things my father's specialty was artificial insemination and infertility, And
He had an office in Los Angeles.
Yeah, he was in California, Thousand Oaks. That's where I grew up. Hey, I need to see endoscopically what's going on, guys.
It's a nice place back then. That was like this.
Oh, Thousand Oaks was beautiful. Yeah, beautiful.
It's changed a lot. I know you have control, okay?
Well, I've heard that it's changed. I haven't really. No kidding. That's exactly where I grew up, Thousand Oaks, California. Yeah, beautiful. At least it used to be. I don't know. Been there in a while. I just thought it was odd that my dad got into that. I guess it was kind of a new thing back then, and it was pretty hot, you know. But it was funny. My mom.
He was an innovator.
He was an innovator. I mean, I created this technique, but I guess you're right. I built on endoscopic, someone else's discovery. Because I didn't discover endoscopic spine surgery, but I developed a side shoot of it, so to speak, that's the most successful way of doing it. I need the pedal, guys. So, yeah, the side shots, right? Of course, the patients never met the donor. And they did something back then where they would mix the husbands with the donors together. So there was always, maybe it's the husbands, right?
Right. But in this case, they're paying the copay to the donor.
Yeah. 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 Yeah.
Sorry, I have a 40 cents.
Hey, Luis. Yeah, he's doing okay, but maybe a little bit towards me.
Yeah, so what was the day right?
I don't know. I could just never get into OB-GYN. You know, it's funny, when I went to USC Med School in Los Angeles, where my dad was faculty when he was alive, but he was already passed away years before I got there. But some of the OB-GYNs knew him, and they actually, Dr. Michelle, for example, he was a chairman. When I went to USC for med school, and I rotated through OB-GYN, he actually came and introduced himself to me, which I thought was nice. He said that he missed my father, and my father was a great faculty member at USC, and really added a lot to the department. So it was kind of nice to have that.
You must have delivered a lot of babies there as a med student. Don't they have a
Me?
very large?
Yeah.
Yes, right?
Yeah, so you do deliver babies at USC as a med student, you're correct. And it was kind of a running thing that you always would try to get, a lot of the med students would try to get the babies named after them. That was kind of the thing, you know. Nobody named their baby after me, but
There was no R's.
Renault Auras, that's right. But the OB-GYN department, by the time I got there as a med student,
Right.
it was mostly, so OB-GYN, is traditionally like in the 70s, 80s, 60s, it was always a male-dominated field where it was men that were the OB-GYN. But that's changed over the last, 30, 40 years, right? There's a lot more female OB-GYNs because it's kind of a surgical field. So it's always been pretty heavily male-dominated. And by the time I got there at USC, it was a lot of female residents, and they weren't very nice to the guys. Let's just put it that way.
Right.
They actually felt OB-GYN should be a women's specialty. Like they were forcing guys out of the field. And of course, they saw me as, the son of an OB-GYN who was very successful in his day. And they were threatened, They were threatened by men coming into the field because they felt it should be a woman specialty, a bit sexist. So I said, listen, you got nothing to worry about. I'm not going into OB-GYN. I'm going into neurosurgery.
So you knew when you were relatively early on in the med school training.
Yeah, I came to med school at USC. There's the tear, by the way, right there. I came to USC believing I was going to be an orthopedic surgeon. And I spent my whole first year telling everyone I was going to be an orthopedic surgeon because that's what I was going to do. Because orthopods, orthopedic surgeons, they're the athletes. If you're an athlete in high school and an athlete in college, you go into medicine, usually you become an orthopedic surgeon. Like all the football players, soccer players, all the athletes end up usually becoming an orthopedic surgeon. So for me as a soccer player, I wanted to be an orthopedic surgeon. But then when I got to med school, I started doing orthopedics, and I got to be honest with you, I was like, this is boring, really boring. Measuring joint angles and implant length and all that stuff. This is like really, really boring. So then I spent like the later half of the year not really sure what I wanted to do. And the last course we take, the first year, is neuroanatomy. That's the last course. They save it for last because it's the hardest.
That's a great class.
And I had no neuroanatomy or neuroscience experience in college because I just never took the courses. So I didn't know what neurosciences was all about. But anyway, I took the neuroanatomy course and basically aced it. But along the way, I fell in love with the brain and the spinal cord and the nerves, just the whole nervous system. I even liked behavior, like human behavior, behavior abnormalities. I liked understanding like anxiety, depression, psychosis.
Kluber-Bucy syndrome.
All the weird stuff, right? And so I just kind of gravitated towards the brain and the nervous system. And so by the end of my first year, after I finished neuroanatomy and aced it, I realized this is what I want to do. I want to be a neurosurgeon. And that's when I went and met the chairman, Marty Weiss at USC, and he became my mentor. And, the rest is history. But I didn't know I wanted to be a neurosurgeon until basically the end of first year of med school. And at that time, I wanted to be a pediatric neurosurgeon. I wanted to take kids' brain tumors out, save them. Such a horrible fate, So I went to neurosurgery residency believing I was going to be a pediatric neurosurgeon. And when I did my pediatric neurosurgery rotation, I got really turned off by a lot of things, but the parents were number one. And it's not the parents' fault. I mean, I would be the same way. They're just completely stressed out. And like you spend so much time just sitting there talking to them. And I am not a talker. God did not bless me with a mouth. Sure, I can teach, but I'm not like the kind of person who can sit there and just talk to you about how your child's dying. It's too depressing for me. And I just couldn't handle it. Takes a special person to be a pediatric neurosurgeon. Really does. Pediatric oncology, anything to do with kids that are dying, which I'm not blessed with that ability. So I realized I had to find something else to do. And that's when I fell in love with epilepsy and the brain. The misbehaving brain. So I did a fellowship and NIH funded research in epilepsy. And I was ready to go become an epilepsy neurosurgeon, academic epilepsy neurosurgeon, some university. And just 2 years out from graduating, I met Dr. Jeff Henn. And Dr. Henn came from the Barrow Neurological Institute, really top spine training program in the country at the time. And he had just graduated. He was trained by Curtis Dickman and Volkner Sontag, two top spine surgeons. Just the whole program over there was top. And UF hired him to come over and expand the spine program. Yep, thank you. Anyway, my chief resident ahead of me wanted to be a vascular neurosurgeon. So all the aneurysms and AVMs he gobbled up, every single case. And he left me with the spine cases that nobody wanted to do. So of course, as the senior resident, not the chief resident, I was stuck with the spine cases. It was either that or it was some other boring type of surgery. So I ended up, it's like shunts. There's no way in hell I was going to do shunts. So I ended up doing all these spine cases, and as I'm doing them, I started seeing the patients that he did surgery on. They did really well. Like their pain would go away, and they could go home in a couple of days, usually less than a week. Whereas all the brain tumor patients and epilepsy patients, they were in the hospital for months, on life support and shunts and all kinds of miserable side things that happen. So I quickly recognized that spine could actually be a very happy field in medicine, that you can actually cure people of their condition and they get them back to being normal. So here I am, a spine surgeon.
We have a question from Jason on Facebook.
All right, I'll take Jason's question. Thank you.
He asked, what is the risk of disc space collapse and future pain from this procedure?
What is the risk of disc space collapse and future pain from this procedure?
Correct.
The risk of disc collapse is virtually zero. I know it may seem like we're taking the disc out, but we're not. We're only operating on a very small part of the disc. Jason, for reference, you see that glass tube right there? That's 1 millimeter across. So this is it looks big. It looks like we're taking the whole disc and operating on the whole disc, but we're not. We're only operating on about 7 millimeter space, 7 by 7 millimeter space of the disc. So there is no risk of collapse. We're not even taking out any of the normal disc. We're taking the herniation out. So we're not taking any of the actual cushion. I need 3 minutes, doctor, 3 minutes. So we're not taking any of the actual cushion or disc out. We're just taking the part out that's already been out of place, pushed out of place. Now, if the patient does what I tell them to do with respect to their restrictions, they don't do any heavy lifting and they don't bend at the waist and re-injure this disc, then the chance of re-injuring and collapse of the disc space is zero. It doesn't happen. Now, the chance of having your disc space collapse if you have a microdiscectomy or a laminectomy is 100%, because the surgeon is not actually fixing the disc at all with a microdiscectomy or a laminectomy. Okay? But with the Deuk laser disc repair, we're cleaning out the herniation and allowing the disc to heal itself. And by doing so, the disc will heal. So its future degeneration will stop. Let me have the grabber. Come on.
So that's what I'm saying. You count like this, you grab it here and then grab it, and then go. Okay. Like this is okay. Sign quick. There, do it. It's usually around here, right? This is
All right, laser. Pretty much almost done. When you hand me the laser fiber, make sure I grab it before you let go. Okay? Otherwise, it's going to flick out and get contaminated. All right, guys, just about done. Any other questions from our audience? It's a great question we've had.
No current questions, Doc.
All right, have you run any of our animations to show them what we're doing?
doing
Let's
a,
run the video animation of the Deuk laser disc repair lumbar to show them how the Deuk laser disc repair works. That might answer a few questions people have.
Disc herniations are a common cause of chronic back pain. The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
Okay, we've finished up our procedure, and we're just cleaning out the wound with our antiseptic. I don't need any more.
Okay. So now we take it out. Shake it before. In front of the
All right. I'm sorry?
got a great blood pressure.
Good. Thank you, doctor. So we're done. Going to take the tube out. I'm going to show you the incision. Have we seen the incision on the other side?
No, yes, I'm gonna work on that. Scope up, please. Thank you.
All right. Come on over and let me show you the incision here. Can you see right here?
yes, I can see it.
7 millimeter incision. So we fix one disc through one incision. And actually you can fix up to 3 discs with one of these incisions. But it turned out that this patient only needed 1 disc fixed from the left side and 1 disc fixed from the right side. So that's why I had to make 2 separate incisions. Great job, everyone. Any more questions? Type them up for me. I'll come answer them for you. But everybody, great job today. This was going to be our last surgery. Why don't you go ahead and run show one of our patients who had the procedure done, and I'll be right there to answer questions. Dr. Ardik Majan here at Deuk Spine Institute. It's Groundhog Day, I believe, right? February 2nd, so 2/2/2022. And I'm here with one of my patients who traveled from, where did you come from?
Tennessee.
Tennessee. And why would you travel from Tennessee to Florida to Deuk Spine Institute?
I have been miserable for months, and I found you and did a consult with you and knew this is where I needed to come for good treatment and relief.
And what kind of problem were you having that brought you to Deuk Spine Institute?
Severe lower back pain, which turned into sciatica, and it was down my left leg constantly. I slept about 2-3 hours a night at most, and I could not sit for more than 5 minutes, and I had to be standing up.
And did you try some other treatments in Tennessee or elsewhere?
I did. When this whole thing started and it was a bad flare, I thought I'll be able to work through this. Chiropractic, physical therapy, 2 spinal injections, massage therapy.
And how did you know those treatments did not work for you?
I had no relief at all. My sleeping continued to get worse, and my pain was never better.
And do you have relief now?
Absolutely. I would say I have 95% relief.
Awesome.
And it's amazing. After surgery yesterday, I put on a back brace. I walked out of here. I sat down yesterday for probably over an hour and had lunch. Last night, in bed, I had 0 pain. It's a miracle.
Well, we're very happy that you're doing so well. And your surgery was a great one because we fixed 2 discs. You had herniated disc at L4-5, L5-S1, and you can see in this footage right here that we grabbed the herniation out, and it was one of the herniations was really big, and it was really gratifying to get it out because it was resting on your sciatic nerve. Once we took it out, I think your sciatic nerve probably felt a sigh of relief.
Yes, absolutely.
Yeah, and the surgery went very well. The laser debridement of the annulus went well, and I feel like your pain's going to be gone. It's not going to come back.
I would agree.
All right, very good. Well, is there anything else you want to tell your viewers?
Folks, if you're suffering and you're not getting relief from those non-invasive therapies, then come see Dr. Deuk and have him look at your MRI and give a diagnosis. And if you need to have surgery, you come down here. He will take good care of you, and so will his team.
I really appreciate that. Thank you so much.
Thank you.
I'm Dr. Ari Deuk-Majin. It's January 26, 2022, and I'm here with one of my patients who you underwent the Deuk laser disc repair on your lower back for some herniated discs about a week ago.
Yes,
How are you feeling today?
unbelievable. For almost 3 years, I had lower back pain, and it just, it just nags at you, wears you out. And then I came here, and you were the first one. I went to 2 other surgeons, and neither one of them picked up what was wrong with me, even though I had the MRI. And you came in, and you told me exactly what was going on, and you performed the laser surgery, and I'm like a different person.
Yeah.
A week later.
Yeah, you were a different person the next day, right? The day after, you had no pain, remember?
No, absolutely.
Yeah, so that pain's gone for the rest of your life. How does that make you feel?
New life.
Good. And, a long time ago, remember when people did something great, you said, what are you going to do now? They said, I'm going to Disneyland. You already went, I can see.
No, my wife's a big Disneyland fan.
Good for you. All right, so sounds like we helped you with your back pain, and it sounds like you're very satisfied.
Oh yeah, I'm recommending a friend of mine in Connecticut to come here. You have to come here. If you go anywhere else, I really think you're going to be wasting your time. So this guy just looks at you, and he can tell what needs to be done. He's a fantastic talent, and I'm very grateful that I came here.
Well, we're grateful you did too, because it's going to change your life for the better. Congratulations.
Thank you, Doc.
You're welcome. Good morning, I'm Dr. Deuk-Majin. I'm here with one of my patients, and you traveled to Deuk Spine Institute here in Florida from where?
New York, Poughkeepsie, New York.
Awesome. And why did you come from New York to Deuk Spine here in Florida?
Because I heard that this was the best place for me to go.
What kind of problems were you having that you needed to come here?
I had lower back problems and numbness in my leg, which was my left leg. This was the best place for me to come.
Okay. So you had back pain, sciatica down your left leg, pain shooting down the left leg.
Yes.
And that was just yesterday, right? When you
yes,
had
that's
that.
correct. Yeah.
And what, do you still have your back pain today?
No more back pain.
It's gone.
Go on.
And is that because we have you doped up on powerful painkillers?
Nope. None
No, it
whatsoever.
isn't. Did anybody in New York offer you spine surgery to fix your back?
Yep. Yes, they did.
Yeah.
And they wanted to fuse it.
Yeah. And you've had surgery before. You had a microdiscectomy, and that helped you for a little while,
Yes.
but the symptoms came back.
Came back.
Yeah. All right. Well, they're not going to come back this time. So what do we do to make your pain go away?
You fixed my back. I did orthoscopic.
That's right. Arthroscopic spine surgery called the Deuk laser disc repair. So leg pain's gone, back pain's gone.
Everything is gone.
You happy?
You did. Very happy.
You're smiling.
Yeah. I'll tell you.
Congratulations.
Thank
Yeah.
you so much.
We did it all through a 7mm incision, just that big. And you can actually watch that video right here, an animation, to see what it looks like to do the Deuk laser disc repair.
A Band-Aid sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own.
So now that your surgery is done, what are you going to do?
I'm gonna go home and enjoy my life.
Good for you.
Enjoy my life.
Congratulations.
I am very happy.
Anything you want to tell your viewers?
Other than this is the place to come, it's worth the travel.
Disc herniations are a common cause of chronic neck pain. The inflamed annular tear causes neck pain. Inflammation of the nerve roots causes arm pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. It can take up to 12 months. If you have a herniated or bulging disc and neck pain, submit your MRI for a free review at www.mri.deukspine.com.
Deuk Laser Disc Repair, a comparison with traditional spinal fusion surgery. A symptomatic disc causing neck or back pain can include bulging discs, herniated discs, ruptured discs, degenerative discs, protruding discs, spinal stenosis, radiculopathy, and sciatica. This patient can choose traditional fusion surgery or the Deuk Laser Disc Repair to help alleviate the pain caused by and within the symptomatic discs. Here, two patients with comparable disc injuries are treated. On the left, the highly invasive spinal fusion, and on the right, the least invasive Deuk Laser Disc Repair. The spinal fusion requires a very large incision, usually leaving a large scar. The Deuk Laser Disc Repair requires only a very small incision, usually less than a ½ inch long. In this small opening, a cylindrical rod, called a dilator, is inserted to gently spread the muscle to create a small passage and guide through which the surgery is performed endoscopically. The incision for the fusion continues, including penetrating the skin, fat tissue, and multiple layers of muscle through to the bone. With the Deuk Laser Disc Repair, a mallet is used to advance the tip of the dilator into the symptomatic disc. A tube, called the tubular retractor, slides over the dilator and is carefully positioned into the disc, again using the mallet. The rest of the entire Deuk Laser Disc Repair surgery will occur inside this narrow tube. To access the spine, the spinal fusion requires the muscle to be separated from the vertebrae. This very invasive action causes trauma and permanent damage to the muscles. Whereas in the endoscopic Deuk Laser Disc Repair, the muscle is not damaged. The endoscope camera is inserted into the tubular retractor to allow the surgeon to guide the laser inside each symptomatic disc. The fiber optic laser used in the Deuk Laser Disc Repair is manipulated with great accuracy to remove only painful inflammatory tissue from the disc. In this highly magnified view, the laser is used to precisely remove damaged disc material that is causing the pain. The laser is debriding, or essentially vaporizing, damaged tissue in the disc's outer layer, or annulus, specifically at the annular tear, the source of the rupture or herniation and pain. After the fusion patient's damaged discs are removed, a metal or plastic cage housing bone grafting material is inserted in place of the removed discs. Fusion hardware, by design, is to fuse joints that normally move, preventing natural movement in the damaged portion of the spine. Whereas with the Deuk laser disc repair, there is no loss of movement. Normal movement and flexibility of the disc and joints is preserved. Once the laser has removed the painful part of the annular tear, the endoscope and tubular retractor are removed, leaving less than 1/2 inch incision in the skin, which is closed with a single stitch, Steri-Strips, and a Band-Aid. Total time for the Deuk laser disc repair surgery, approximately 1 hour. The fusion, however, is still underway. Holes in the spine must be tapped in preparation for the large screws that anchor the fusion hardware. The Deuk laser disc repair patient is in recovery usually 45 to 60 minutes before release to go home. Meanwhile, bone graft material is placed throughout the fusion surgery site. These morselized pieces of bone will eventually grow together to help promote the fusion process. The Deuk laser disc repair patient is soon back home, enjoying life, with a very fast recovery, allowing normal activities without pain. Average surgery time of a traditional 2-level fusion is 2.5 hours, with an additional 3 to 4 hours in the recovery room. As we've seen, in comparison, a spinal fusion requires a much larger incision and results in a significant amount of scar tissue. The Deuk laser disc repair's 1/2 inch incision leaves no scar tissue around the spine or nerves. A large amount of bone is removed with a spinal fusion. With the Deuk laser disc repair, no bone is removed. Each disc is accessed through a natural opening in the spine. The entire disc is completely removed in a spinal fusion, even though only 5% may be damaged. The Deuk laser disc repair leaves the normal parts of the disc in place and removes only the painful annular tear on the damaged disc. Fusion requires hardware, including screws, rods, plates, etc. The Deuk laser disc repair does not require any hardware. The patient is totally hardware-free. Fusion surgery is very invasive. Cutting and moving the muscle structures and tissues for a spinal fusion causes trauma, resulting in permanent damage to the muscles. Whereas with the Deuk laser disc repair, there is no damage to the muscles. The Deuk laser disc repair is the least invasive surgery available to repair a damaged disc. With spinal fusions, patients are required to take highly addictive narcotic painkillers, which can cause constipation, bowel, and bladder complications. Due to the minimal pain, narcotics are not needed with the Deuk laser disc repair. Spinal fusions have a high risk for infection. The Deuk laser disc repair has a very low risk for infection. In the 7 years the Deuk laser disc repair has been performed, there have been no infections. Spinal fusion surgery has a very long recovery and requires a great deal of physical therapy and time to heal from the trauma in the muscles and the spine itself. Whereas the recovery from Deuk laser disc repair is in a matter of hours or days, rather than weeks or months. With fusion, the spine is being fused together, losing movement. Whereas there is no fusion with the Deuk laser disc repair. Normal movements of the joints in the spine is preserved. Spinal fusion results in loss of mobility. There is no mobility loss with the Deuk laser disc repair. In fact, most Deuk laser disc repair patients experience improved mobility after the surgery. The Deuk laser disc repair is FDA approved. All the instruments and equipment used are FDA approved. This proprietary surgery itself has been peer-reviewed and published and is performed exclusively at the Deuk Spine Institute. With the highest published success rate of 95%, the Deuk laser disc repair is proven to be the most successful and least damaging spinal surgery in the world for the treatment of symptomatic damaged disc.
Hello, I'm Dr. Deuk Majan, and we have just completed a surgery on a patient who had 2 herniated discs, one at L4-5, one at L5-S1. And we did the L4-5 disc on one side, we did the L5-S1 on the other, because the herniations were actually asymmetric, one on the right, one on the left, affecting the nerves. I apologize for the blurry picture. We're still trying to get our camera to adjust. But anyway, we do have some questions. The first one is from a patient who asks, are you able to do your surgery with a patient that has multiple sclerosis or MS? The answer is yes. We've done our surgery on MS patients before and it works quite well. It does not fix MS, obviously, but we don't exclude patients with conditions like multiple sclerosis. Because the Deuk laser disc repair endoscopic surgery is so gentle, minimally invasive, no blood loss, and the hemodynamic effects on patients are minimized, we're able to do this surgery even though other types of spine surgery may be excluded. So if you want to know if you're a candidate for the Deuk laser disc repair, go to mri.deukspine.com and upload your MRI scan and let us know more about your condition. See if you're a candidate for the Deuk laser disc repair.
All right, and one more question from Michael on YouTube, and he asked, can degenerative disc disease be hereditary related?
Yeah, great question, Michael. So Michael from YouTube has asked, is degenerative disc disease, is there any kind of hereditary component to it? The answer is absolutely yes. What I found is that the propensity for people to have painful disc injuries is definitely runs in families. And I've been doing this 26 years now as a neurosurgeon, and my focus has been spine for, well, the last 22 years out of 26 years. And I definitely see that disc problems and back pain and neck pain run in families, for sure. Very, very commonly run in families. So I think there is a genetic contribution. I don't know exactly what it is. I don't know if it's more on the inflammatory side or more on the weakness of the annulus and propensity of the annulus to tear and disc to herniate. I'm just not sure what genetic alteration or predisposition makes people more likely to have painful disc herniations. Great questions. I've enjoyed our time together. I want to say thank you to my crew over here. They've done a great job of broadcasting today's surgeries. We have 4 more surgeries on Thursday, and then we have surgeries next week as well. I'm back in town. I've been out of town for the last 2 weeks, overseas promoting Deuk Spine Institute and our services. Thank you.